Okay, good evening everyone, and welcome to the Helps Global Association World Diabetes Day webinar. So my name is Alison Agbor, and I'm honoured to be your moderator and your host for this evening. So World Diabetes Day is a very vital opportunity to raise awareness about the global impact of diabetes and highlight the unique challenges faced by less developed regions. So this year we focus on innovations and opportunities in addressing global challenges in diabetes care. So at Helps Global Association, we are dedicated to empowering underserved communities, especially Africa, Asia, so ethnic minorities, by improving access to healthcare, fostering education, and driving sustainable innovations. So tonight's webinar aligns with our mission to bridge gaps in healthcare systems, address misconceptions, and advocate for equitable solutions that transform lives. So a quick overview of the event. So we have two 10-minute presentations from our two special guests. We also have an interactive case study discussion, and we also have live audience polls and Q&A for you guys watching to also interact. So we encourage you to participate actively, use the YouTube chat to submit your questions, engage in the polls, and also share your thoughts. Make sure to leave your name, your where you're from around in the world, and also why you're interested in watching our webinar tonight. Okay, so that's enough from me. So I'm just gonna pass it over to the rest of the trustees. So who wants to go first? So Tumani, Professor Tumani, would you like to introduce yourself quickly?
I'm Tumani Kora. I'm Emeritus Director of Medical Research Council, Unit the Gambia, and founder of the Africa Research Excellence Fund, body committed to developing the next generation of African scientists by focusing on early postdocs to ensure that we retain them in Africa, that they stay and win their own grants and carry their own research relevant to the continent. Thank you.
Okay, excellent. Okay, Everjoy, Lady Everjoy, would you like to present yourself quickly?
Good evening. My name is Everjoy Kurangwa. I'm a registered mental health nurse and company director for a healthcare business. I'm also a trustee for Helps Global, and I'm currently in the process of studying something different, but hoping to impact change through Helps Global within the global community where healthcare is becoming a problem, especially in my country, Zimbabwe. So I would love very much for everyone here watching, if there's any ideas you can give, please run them by myself. I'm going to Zimbabwe. I'll listen to see what I can do in terms of the healthcare system in Zimbabwe, and hopefully Helps Global will impact that change as well. Thank you.
Thank you so much. Okay, and then now we move on to introducing our two special guests. So first we've got Dr. Agbor. So would you like to introduce yourself quickly?
Hi, thanks, Alison, and really a great honor and privilege to be invited by yourself and the Helps community to be on this show. So I'm Agbor Ako, and I'm a consultant endocrinologist. UK, the National Health System. I'm also a senior medical director within pharmaceutical industry, and I've led global teams, and I've invested quite a lot of funds through pharma to the Southern African continent, and also to Southeast Asia and also Latin America. So I look forward to an exciting discussion and to share some of my experiences with you, and more importantly, hear back from you how we can do it, what we can do better to improve healthcare in these underserved populations, as Alison quite eloquently.
Okay, thank you. So I'm looking forward to hearing your thoughts and for you to highlight all your opinions and what you have to say, your words of wisdom this presentation. And then finally, but last but not least, we've got Dr. John Bolideko. Would you like to introduce yourself quickly?
Hi, good evening. I'm Dr. John Bolodioku. I am a life science consultant. So for my sins, I'm a consultant chemical pathologist and a consultant pharmaceutical physician. It gives me great pleasure to talk on this topic, diabetes, which has been a topic I've been involved in both from a diagnostic point of view and from a pharmaceutical point of view, and actually launched quite a lot of these drugs we're talking about in the UK, from things like inhaled insulin to the various biosimilars like Lantus insulin. So it'll be a pleasure giving my experience and talking about these drugs to you all, but also hearing your own views about how we can continue to work and improve the diagnosis and the management of this disease, especially underprivileged groups of people.
Amazing. Thank you so much. I'm looking forward to hearing an engaging and informative presentation from you as well. Okay, so before we quickly start, I'm just going to mention a few things. So I'm going to pose some questions in the comment section for the audience just to reply, let me know your thoughts. Obviously, this is a very inclusive webinar. We want everyone to get engaged. So let us know your thoughts. Any questions you have, we'll answer them in our Q&A section later on in the webinar. Okay, so that's enough for me. So we'll start with our first guest speaker, so Dr. Agbor, and he'll be going through the innovations, the leaderships in diabetes. So do you want to take it away?
Yeah, sure. Thanks. I'm happy to oblige. So I don't want to say like John to my sense, but I think diabetes has always been a Cinderella complication. And just to take a couple of steps back, as you would be well aware, last Thursday, that was the 14th, was the World Diabetes Day. So we should have organized this webinar on the 14th, but for various logistic reasons we couldn't have. And the reason that we organized the World Diabetes Day is just to sensitize people around the incurs on minority healthcare groups around the world. And it's not out of serendipity that you see me wearing this blue ribbon, this blue cycle. So about a couple of decades ago, myself and my then supervisor tried to lobby the United Nations to try and incorporate diabetes as a public health problem. And thankfully, now it's been accepted, and every year around this time, 14th of November, there's the World Diabetes Day. So that's for starters. This webinar, it's important to note that, as I said, it used to be considered as a Cinderella condition in terms of the fact that it wasn't malaria, it wasn't filarial, it wasn't leprosy, it wasn't your typhoid or whatever typically affects people from ethnic minority groups. It was kind of an insidious condition where a lot of the time people didn't recognize it in ethnic minority groups until they were completely and complications. And there are lots of complications that diabetes incurs, and I'll come to that in a second. But it has always been something that we thought, now this is a disease for Westerners. It wasn't a disease for people from any minority backgrounds. Now, to just take a step back and go into the burden of disease, just to let you know that people from South Asia and African origin are at higher risk than the people that we meet around, so Caucasians, in terms of developing diabetes, similar to people from Latino communities, so Mexicans, etc. And the reasons for this are various, but it is much more relevant for tonight's discussion to just understand that in the past we lived in poverty, or relative poverty, I should say, in our indigenous community. Had to somehow mutate themselves such that they would confer us enough energy for the rainy days, quote unquote. And unfortunately, as due to urbanization, affluence, more and more affluence, you say, relative to the days in the past where people used to be hunter gatherers, relative sedentary lifestyles and saturated foods that we can easily find in the supermarkets, those genes that we had, which were more genotype, so they're thrifty, so they were able to conserve a lot of energy, still remain. And unfortunately, they do not understand that the environment we live in now allows us, due to our affluence, we can be able to afford more, to be able to get more energy into our system. And so they conserve it. Unfortunately, what that results in is that we then get fatter, to put it bluntly. Um, and back home, when I used to train in Cameroon, to say you're more endowed if you're fatter, more immature, etc. So that carries that risk. And the same for Latinos, and the same for the so the Asian or Southeast Asian sub community. So we then carry this legacy, call it genes, that predispose us to developing diabetes at a higher rate than other people. And so it's very important that we recognize this risk. Additional to the risk of diabetes, we're also suffering from disease. We know very well, and I've published extensively on this, that if you combine diabetes and cardiovascular disease with inflammation, which is caused by chronic infection and other conditions, then you suffer a double whammy per se. So it is important that we are able to recognize that underprivileged, underserved communities have this double whammy in terms of the prevalence. More importantly, and I think this is the more important to explain, is that we are at higher risk of not accessing, having good, equitable access to healthcare. And John is going to speak to you in a second about the innovations in healthcare. And you'll see that, and I don't want to preempt his talk, that whilst there are new innovations, there's some reservation around how does this apply to ethnic minority groups, and how representative that allows that drug to be licensed, how representative is that population to ethnic groups. So I think these are the things that we need to be mindful of as we discuss going forward. So that's a bit about the burden of disease, which is disproportionately affecting minority groups. And then also there is a lack of evidence to suggest new therapies, or not lack of evidence, but then there's no data, so you can't say there's a lack of evidence. And maybe this evidence is there, but we just don't have the data to analyze that this applies. Diabetes can lead to a lot of complications, and there's what we call macrovascular complications. So big vessels, so basically stroke, heart disease, and also peripheral vascular disease. Predominantly people manifest themselves as pain in the calves or the legs, lower legs when they try to walk, and that might lead to gangrene at the extreme. And then you've also got some small vessel disease, which is usually retinopathy, so eye disease, and that can eventually lead to blindness. So we call it retinopathy. Or the small vessel disease you can get is neuropathy, so people get pains and need painful or sometimes painless sensation. And if you don't feel pain, as Richard Brown, one of my good colleagues and friends, or the elderly colleague and friend, who was an orthopedic surgeon who left from America when I worked in India, a lot on leprosy, said pain was God's greatest gift to mankind. So if you can't feel pain, if you had a pebble in your shoes, you are likely to develop an ulcer because you don't feel any pain at all. Pain is good because it alerts you to danger. So that's neuropathy. The last one is kidney disease. And with kidney disease, I'll just remind folks that I know John is very active in this space. With kidney disease, when it leads to end-stage renal disease, we don't have a lot of ethnic people, ethnic minority groups coming up for organ donation, and there's a huge shortage of it for cultural reasons and a whole host of other reasons. But just to summarize, so it's a burden that's very high, predominantly so for ethnic minority groups, leads to big vessels, heart, brain, lower legs, and to small vessels leading to neuropathy, so nerve damage, the kidneys, and the eyes with blindness. I will stop there, Alison, and I'm happy to take the conversation forward, but I think those are the key bullet points for me.
Thank you. Thank you so much for that engaging, informative presentation. Yeah, some very knowledgeable facts to note down. Okay, so next we're going to move on to Dr. John Bolodioku, who's going to discuss the innovations that we could consider. So over to you, John.
Okay, so Agbor, we're going to do the slidey bits. Are you going to move the slides or bring the slides up?
Have you shared them with me, John? Oh, I can see now. Yeah,
yes.
I will. Let me just download them for you. One moment.
Smashing. Thank you very much.
Yep.
So my presentation today will basically a quick whistle-stop tour of some of the kind of pharmaceutical products that have come onto the market very recently and have slightly changed the landscape of how we try to treat both our type 1 and our type 2 diabetic patients. I've been quite fortunate to have been involved in about, I would say, almost every one of these drugs at some time with the various companies I've worked with in terms of commercializing these drugs in the UK. For my sins, I've been involved in the development of inhaled insulin. I've been involved in, for example, the DPP-4Is, with the SGLT2s, the GLP-1s, and also biosimilars insulin. So those are the diabetic drugs I've been involved in also when they're launched within the UK. So when I'm talking about the drugs, it's also from some very personal experience and very proud to have been involved with the launch of these innovative medicines in the UK. So Agbor, do you want to tell me when you're ready?
Yes, I'm going to share my screen now.
Perfect.
Alison, just give me a cue if my screen is sharing okay.
No screen sharing yet.
So, entire screen. Have you enabled me to share? You probably want to do that.
Yeah, I've enabled you, so it should be allowing you to share the screen.
Okay.
So whilst Agbor is currently working on this on the slides, here I see something twirling. Something's twirling.
And now, John?
It's gone. It's back. It's back. Yeah. Can't see any slides though. I see something up, but no slides. Okay.
Can anyone else see my screen apart from John?
Yes, I can see your screen, but there are no slides.
Yes, we can see your screen, no slides.
So,
Do you
so can
want?
you just tell me what you can see on
Do
my
you?
screen? Because
Yeah, I don't think I can. Can't see the slide. Can't see the slides.
Mhm.
Yeah, I can just see the stream on your screen.
Okay, I'll probably just start to. Yeah. Whilst Agbor's working on that, I'll just kind of go through the slides in my head that I've got. So one of the things when we start to have drugs for diabetes in development, one of the key things we're trying to do is look at what are basically our therapeutic objectives. What do we try to do when we've got these various drugs? Now, the first thing, there are about 6, I would say, buckets we try to look at. One of the things we try to do is look at if the drug is able to reduce the insulin load in type 1 diabetic patients and also reduce the tablet load in the patients who are on type 2. That's one of the objectives we hope that the new drugs are able to do. Second thing we would hope is that it does reduce the HbA1c, which is the glycated hemoglobin, which is basically when you look at the glucose level over the last 3 months. Are we able to reduce that level of glycemic control? A third bucket we try to look at, we hope these drugs can do, is actually reduce the weight of the individual. That's the third one. Fourth one, which we're starting to see, is actually when we look at some of the long-term data, are the drugs able to reduce the risk of cardiovascular events? And because these drugs also tend to be hypoglycemic in nature, reducing of glucose, what we try to do is hope that these drugs do not cause an increase in hypoglycemic episodes. So those tend to be about the 5 big main things that we try to look at our drugs that we use to treat diabetics. And they do try to fulfill and do something in each of those buckets. There's some extras that we hope that they can do, give some form of renal protection, improve post-meal glucose, also probably improve the lipid profile, reduce the uric acid, and also being very convenient in terms of the form, maybe an oral form as opposed to an injection form. So these tend to be all the big things we look at in any new innovative medicines brought into diabetes. So when you actually look at, Agbor, have we brought the slides up? Not yet.
No slides, so you have to
Yeah.
try and manage it out.
Okay, I'll just continue. So when you actually look at some of the guidelines now, for example, actually out there, and I'm going to start with type 2 because before going on to type 1, because most of the drugs are being used in type 2 and are still experimental in type 1. So I'll start with type 2. What you get as the first line therapy for most people, most type 2 diabetics, if not all, is metformin. That's been around for quite a long time. And when you start looking at the second line therapy of drugs now, this is now filled up with drugs that we call the GLP-1 arrays, basically the glucagon-like peptides, antagonist, and SGLT2s, which is basically the sodium glucose channel 2-1s. So those two groups of drugs, SGLT2s and the GLP-1s, have really come and actually made a huge difference to our management of our type 2 diabetics. And if you remember the buckets I mentioned much earlier on, where we're able to reduce the tablet load, reduce the HbA1c, reduce weight, and also, would I say, reduce the cardiovascular events, especially that we're seeing that now with these group of drugs, and they have made quite a difference to now become second place in basically second place. Now, talking about the mode of action of the GLP-1s, the GLP-1 areas work mainly in the gut and the pancreas. What they do is they inhibit gastric emptying, and that way they reduce blood glucose and they reduce glucagon secretion and increase insulin release. And because they tend to, of course, work in the gut and the pancreas, it's not surprising that the commonest side effect that we get with our GLP-1s tends to be things like nausea and some of the gastrointestinal, would I say, abnormalities. Now, there are quite a number of them on the market. I would say, if not about up to 10. And the common thing that we know with these GLP-1s is because they're peptides, they're most, actually, if not all of them, are administered via some form of injection, which ranges from twice daily injections seen with things like Byetta down to kind of once weekly or even once monthly injections in some of them. Now, what has also happened is that a good thing that's happened is semaglutide has now, just recently, there's now been an oral form of it. Novo Nordisk has launched an oral form of a GLP-1, and therefore, from a patient convenience point of view, rather than injecting yourself either once weekly or 3 times a day or once a week, we now have an oral form of a GLP-1. So you can see these GLP-1s have really kind of revolutionized, I would say, our management of diabetes. The second class is an SGLT2 inhibitor. And the way this drug works is it works mainly in the kidneys, tubules. Now, if you consider that with diabetes, what you tend to do is you tend to push out glucose via your kidneys. But the body has a nice way of conserving that glucose, which actually what it does in the proximal tubule, which is the earlier bit of the kidney tubules, your body tends to reabsorb glucose back into the system. Now, these drugs called SGLT2 inhibitors, what they do is they actually block that system and therefore allow glucose to flow out through the kidneys and you pass it naturally. So it's not surprising that, of course, your urine is actually more sugar loaded when you're on these drugs called SGLT2. And of course, the commonest side effect you sometimes tend to get with this tends to be urinary tract infections sometimes, because of course you can now imagine your urine is loaded with glucose, which is quite ripe enough for bacteria to stay in. Now, there are about 5 of them on the market, and they've really also helped in actually the treatment of the type 2 diabetic. Now, as I said, they got some good added benefits in terms of cardiovascular disease, kidney, improving the renal protection, heart failure. So you can start to see a lot of those cardiovascular outcome measures that we didn't probably see in some of the older drugs that have been around. We are now seeing them in these 2 classes of drugs, the GLP-1s and the SGLT2s. And they have really revolutionized, I would say, the treatment of our type 1 diabetics. So what you basically say is they are able to help us reduce our tablet load, reduce the HbA1c, reduce weight, reduce the risk of cardiovascular events. Sometimes there might be a reduction in hypoglycemic effect, but we do see things like renal protection and even some lipid profile. And now we even have an oral form present. So we can start to see these new innovations really have made the difference with our treatment of our type 2 diabetics. With our type 1 diabetics, insulin, of course, continues to remain the mainstay of treatment because we know that these patients don't have insulin. So all we've tried to do is looking at new forms of insulin, trying to make them ultra fast and ultra long. That tends to be the focus of any of the new insulins we're looking, and hoping that they have a very flat action profile, therefore lowering the risk of hypoglycemia. And there are a few ones on the market. But what I want to talk about is how GLP-1s and SGLT2s have now found their way into type 2, into type 1 diabetes. Several of the SGLT2s have been studied in type 1 diabetes, and they've shown very promising results. Although one of them, dapagliflozin, was actually authorized in 2019. Now, remember, these drugs are using together with insulin in these patients, but dapagliflozin was actually withdrawn. Now, there's actually a newer SGLT2, which is actually marketed as a dual SGLT2. So it actually not only blocks the SGLT2 in the kidneys, but also in the gut. So there's a dual action in where it actually stops the reabsorption of glucose. And this is sotagliflozin. This is a very new drug that's come through. It's been, I think, approved in the FDA, and it's also been approved by NICE here in the UK. And I think this is another new drug that really is going to actually revolutionize type 1 diabetes now, where we have an SGLT2 being used in type 1 diabetes. Now, also the GLP-1s have also been studied too in type 1 diabetes, and they're very promising results. But I don't think we've got any one of them that's got an indication yet in type 1, but they are showing very promising results. So we can immediately see that these two classes of drugs, the GLP-1s and the SGLT2s, have made a significant impact in type 2, and they're finding their way into type 1 diabetes. I'd like to just leave with this last drug, which is actually an antibody drug. It's called teplizumab. And this is a drug which now actually has been indicated to reduce the progression of diabetes. So this is interesting. This is a drug that's used to prevent the progression of stage 2 to stage 3 for type 1 diabetes. And basically, this is an antibody drug which binds to the T regulatory cells and also the CD8 cells. And effectively, what it does, you get a whole range of cytokines coming out, and those cytokines basically try to keep the beta cells alive. And by keeping your beta cells alive and increasing your mass of beta cells, you're able to kind of keep your insulin going and producing, and therefore reducing the patients from moving from stage 2 to stage 3 type 1 diabetes. This is a very new drug. I think even here in the UK, it's just been going through its approval. I don't even think NICE has seen it yet, but actually I think this is another new drug that's actually going to be, I would say, be included with the armamentarium that we have with type 1 diabetic patients. And this is actually now moving on to prevention of diabetes as opposed to even the treatment of diabetes. So I think in that within 9 minutes or so, I hope I've been able to kind of give you a quick whistle-stop tour of some of the new drugs that are actually out there that are changing the landscape of the treatment of diabetes. But something that Agbor said earlier on is the importance that these drugs are mainly being tested in the Caucasian population and are not tested actually for one reason or other with either lack of recruitment or the lack of the minority people coming forward to put themselves for these trials. So these drugs need to be tested in those underrepresented populations. Thank you very much.
Thank you, John, for that very thought-provoking presentation. Your exploration into the pharmaceutical innovations was very insightful. And yeah, it's inspiring to see how advancements in diabetes care can drive healthy equity globally. So yeah, thank you for that. Okay, so now we're going to move on to the case study discussion. So I've got a scenario here, and I'm going to ask our two panelists a few questions on how they will tackle this situation. Let me just put you guys onto the screen as well. Okay. All right, there we go, perfect. Okay, so the scenario is, so in a rural African community with high diabetes rates, access to healthcare is limited due to lack of specialists, financial challenges, and inadequate infrastructure. So the local healthcare centre wants to introduce digital tools such as telemedicine and remote monitoring, but lacks a clear strategy. So the first panelist question is to you, Dr. Agbor. So what leadership strategies can healthcare leaders in underserved regions employ to address these barriers?
Thanks, Alison, for that question. So, John has raised some thought-provoking issues around semaglutide then bring it to the market 10 years ago, and also on faster acting and longer acting insulins. FIASP, I was charged with the global team responsible to see how we can disseminate information around that. So coming to your question, Alison, to the point around utilizing telemedicine in diabetes care, but they don't have a strategy. What I would say is that a strategy is usually what we'll call in corporate jargon a strategy house. So you have in a strategy, then your goals and your deliverables and your stakeholders. So all of that is put together in one house. And then for each of the strands of your strategy house, you're able to pick out what your deliverables would look like. I think in the case of telemedicine in diabetes, um, it it is in its early days because first and foremost, I would say that in a remote area, we don't have continuous glucose monitoring. So you've got John probably alluded to this in terms of insulin. You can have iteratively monitor somebody's blood sugar and it's connected already to the web. And you can remotely see it and tell them that, hi, your blood glucose is 3.5. You better need to stop, get some sugar drinks or something, or it's gone up to 20. You probably need to get your injections now, or drink some more water so that you don't get into hyperglycemic coma or something of that sort. So I think it has to be bespoke, and this comes to the point that I made earlier around not to necessarily just suburban or underserved populations because they may not have the technology or access to the monitoring device that requires them to be able to really utilize the power that telemedicine can bring in terms of optimizing outcomes. And this is something that we continue to advocate at a higher global level where we are trying to utilize philanthropic organizations like the Bill and Melinda Gates Foundation, like Wellcome Trust, and all those stakeholders. And Timan is doing it way through RF to see how we can get funding. And to be able to utilize telemedicine, you need to first of all get funding for these technologies that are enabled by telemedicine, because without remote communication, even if you're able to monitor somebody's glucose and they don't have access to internet and all of that, then that is not workable. So it's all good and fine usually saying that let's adopt this technology, but they have to be supported by the relevant resources to make sure that they can deliver the right outcome in the ground is detected by this whatever sensor you've got. Is communicated to whoever is your specialist provider, and they can give you advice that you can act on, and then that improves the outcomes for everyone. So that strategy has to be joined up and should be supported by sustainability, which means that local governments or healthcare priorities needs to be aligned to this, because even if you pump in money, as I've experienced when I was head of the Africa NCD Open Lab in GSK for 4 years, um, when you leave and you stop funding from dries up completely, and then there's no sustainability, and it's no good at all because people are used to something that works well and then they can't carry that through. So I think the strategy has to be bespoke to the local environment, make sure that it's accessible, it's actionable, and also it's sustainable over the long term, I would say.
Thank you so much for that, Doctor. So we've got a quick comment here from Afi, and he's mentioned that the cost of teplizumab, hope I'm saying that correctly, is extremely high and clearly not going to get to remote settings any day soon. The search for preventatives that can be used in these settings should continue.
Yes, I would concur with that, and John might add to it. So teplizumab, the story is a long story, and Provincial Bio initially started developing it, then it went down the line to a biotech industry, and then came back to Novartis, and it's gone round. It is one of those things I'll call a Cinderella drug. So it acts on a specific type of T cells called CD3s. and it's developed immune tolerance. So rather than your body recognizing your islet cells in your pancreas as foreign and therefore destroying it and causing you to have type 1 diabetes, like John alluded to, it is trying to promote immune tolerance through encouraging the CD3 plus cells to work in a different way. So that's how it works fundamentally. It is early days yet. It's just been licensed in the US. That was just for 11. That was around November. So it's early days yet. I feel like yes, we should go for lower or more accessible ways to prevent diabetes. Type 1 diabetes is hard to prevent because of its inherent genetic nature. But there are other things you can do, like vitamin D supplementation and the rest of that. And there are also forms of diabetes that that present themselves in African populations. But what I'll say, generally speaking, is that for teplizumab, for instance, it's early days yet. It in long-term population studies, and yes, it's expensive at the moment. But I think CDC Africa, which was only launched, I think 2 months ago, have launched a seminar, and they're trying to collaborate with LifeArc. As Tumani will know this because he's also one of the advisors on LifeArc, to try and see how they can produce cheaper monoclonal antibodies for underserved populations. So the jury's out, and the hope is still there.
Thank you for that. Thank you for that, Dr. Agbor.
I think Alison is on mute.
So the next question is directed to Dr. John Bolijoku. So I've got here is, how can pharmaceutical companies adapt solutions to meet the needs of rural communities in Africa?
Yeah, I mean, I think yes. So, thanks, Alison. Thanks for that. Yeah, I think the first thing is actually understanding the problem on ground, because I think many of the times we tend to think it's for many of our so-called medium low resource countries that it's the same thing across the board. Lack of resources, lack of trained personnel, lack of financial inability. But what shocked me and surprised me is I did a survey many years ago in Nigeria and found out that they had all the drugs there present. All the drugs were actually there in the country. They could be bought in the country. Now the question is the price of the drugs. So there you could see the drugs were actually accessible, but then actually the people could not have access to the drug because the drugs were very highly priced. So, and again, the question is that who sets that and how does that? Is that the pharmaceutical industry? Is that the distributors in the countries? Is that the government? There's a lot of interplay there. And that's where I think that the pharmaceutical industry probably has to look at the different needs of the different countries and what they want. I mean, some of them might actually be most important in actually diagnosing diabetes first. And the question, as Agbor just pointed out, some of the high continuous glucose monitoring that we all have with people putting patches on might not be accessible there, and they might have to be doing it on just paper diaries with a basic glucose meter. We also know that even that itself is difficult, because where you get the average person testing with their glucose strips, they might only do it twice a week or once a week, where everybody here probably does it every day. In some of those countries in Africa, they only do it twice a month or 3 times a month. So I think a big thing here is the finance, and where the pharmaceutical companies can come is help with that, in terms of working with the diagnostic companies, distributing the glucose meters, making that packaging it together with their pharmaceutical products, doing a combination in what I call a diagnostic stroke pharmaceutical solution for the respective country that fits the price for that particular country and for that group of set of people, because you would have some of the elite people in those countries who can afford some of the drugs and some of the Western style of drugs and some of the CGM. So I think the pharmaceutical companies can do quite a lot. But I think the first thing that the pharmaceutical companies need to do is make sure that the trials are actually done in those people. What people also tend to forget is that clinical trials can also be seen as a way of access of medicines to people. And if actually doing some of those trials in Africa could actually be of benefit to those people, so they not only just gain data from the underrepresented people, but to those people who take part in the trials, they would have access to the new trials. So I can see the pharmaceutical industry is really, even right from the clinical trial point of view, investing in these underrepresented groups of peoples or economies actually out there, all the way from the clinical trials, diagnostics, and the pharmaceutical interventions. So there's quite a lot for them to do.
Thank you so much for that, Dr. John. Okay, so thank you both for the contributions to the case study discussions. So now we're going to move into our live Q&A session. So I've got a question here earlier from Afi, and this is open to both. So he mentioned that there has been worry about loss of muscle mass alongside weight loss. Is this something we should be worried about?
We're going first. Who's going first?
Yeah, I'm sorry. I imagine Afi is very well embedded in the topic. So is that for type 1, type 2, or both? Is it possible to just ask Afi a loss of muscle mass? So wasting is a condition that we see with type 1 diabetes, obviously. And you see people getting thin, they drink a lot of water, and they're losing muscle mass because they are trying to digest the muscle to develop as much energy as possible, because insulin is not getting into the body. And so that's why they get very thin, and they get chaotic actually by the time you see them. And they can get into very severe conditions such as diabetic acidosis for type 1. Now, that's not to say in type 2 you can't have a loss of muscle mass. This is usually masked by the fact that type 2 diabetes, people are usually obese, they're overweight, kind of fat and muscle, unless you use a bioimpedance measurement where you sink them in the water and you do in experimental situation, you just measure their weight. So it's really hard to disentangle what is their weight that is muscle weight versus what is fat weight, which is the bad thing you don't want to have. And that is one of the things that allows me to just mention the people who are trying to lose weight when they are overweight because they've got diabetes, and the doctors ask them to lose weight. You realize the first 6 months, John is laughing, but frustrated and said, I've done all you've asked me to do. I'm not losing weight. I said, what I say to them back is that stay the course. You're losing fat from muscle. Muscles are protein. They weigh a little bit more than fat. So over time, you begin to reap this benefit. But beyond the losing weight, the fact that you're physically active or you're having a healthy diet as you're trying is going to improve your cardiovascular health overall. So the fact that you're not absolutely looking at your scale and saying, I was 66, now I'm 66, I'm 66, I'm 65, don't give up, because it's an important of populations when I was in Cameroon practicing diabetology. But in my nearly 20 years in the UK now practicing, and even as recently as this morning, you still get people who come to you and say, I'm doing everything you're asking me to do, but doc, I'm not losing weight. What do I do? I said, keep doing it. So I don't know if I answered Alfie's question clearly, but I think it is probably not a useful public health message to focus on whether it's muscle weight or non-muscle weight. is that you're exercising, your diet is okay, you're not smoking, you're drinking reasonably, so you're not increasing your overall risk. And also you're having your vegetables, your 6 portions per day of fruits and vegetables, etc. And if you did all of those, then you are overall improving your cardiovascular risk, compared to someone who doesn't do that. Now, the point I would like to highlight also is that diabetes is not a disease per se, it's a condition that predisposes you to having other diseases. So I mentioned gangrene, I mentioned kidney disease, I mentioned neuropathy, so painful neuropathy, or you can feel sensations in your feet, and I mentioned blindness. And those are the core ones, but you also have acute complications that we discuss in ketotic, getting to coma, different forms of acute conditions, but also infections. Usually the skin, the urinary tract, and the lungs are the key organs that get infected quite often. So it is a holistic approach, generally speaking, and to say that whatever you do to reduce your blood sugar, whether it's exercise, and all the measures, pharmacological, as John has eloquently elucidated, that's good for you. And that's the key message. And it is a chronic condition, so don't think that, well, all right, I've taken this tablet or insulin and my blood glucose are fine, so doctor, can I stop it? You get a lot of that. And no, it is not like malaria where you give yourself chloroquine or quinine or whatever is cured and that's fine. No, diabetes, you're only well controlled because you are taking the medicines. The moment you stop taking them, it will rebound. Similar to, it is down there. If you leave the balloon, what happens, it comes back on top of the surface. So that's the way you should look at diabetes. Sorry, it's a very long answer. Alison, I don't know if you're still there, but tell me one word or not. John, anything to add to that?
No. I think you eloquently sorted it all out. I think the only thing, of course, that I just add, of course, is that we know that with insulin, one of the disadvantages of insulin is actually you put on weight if you're on insulin. That's, which is interesting, because it's type 1s, you get a lot of them starting them on insulin, they actually start to put weight on. And if you look at the SGLT2s and the GLP1s, those are drugs actually that help in weight reduction. And we know some of them have even now got a license in actually weight reduction. But of course, the important thing is, does that weight, first of all, the weight loss that's seen is about 20, I think 30%. It's not, I wouldn't say you go from kind of really very obese to kind of an extremely slim person. You obviously lose weight. But I think it's, as you rightly pointed out, the weight loss is probably related to the type 1 disease itself or condition. But of course, when it comes to the drugs, insulin increase weight, and the oral hypoglycemics like GLP-1s, they reduce weight. So.
Yeah, that's great. Alison, you back now? Sorry, we lost you for a few seconds.
Yeah, no, so I think it was my connection. But yeah, no, thank you both for answering. Because I think Afi, he mentioned here that the weight loss question was in regards to the use of GLP-1 medicine.
That's what I thought, exactly.
Yeah.
So.
But yeah, no, thank you. So I've got one final question here,
Okay.
so I'm cautious of time.
That's great.
So the final question here I've got is, so artificial intelligence is transforming healthcare globally. So what role do you see AI playing in addressing diabetes care differences in underserved regions, particularly in diagnosis and patient management? So John, would you like to start first?
Yes. Well, I mean, to be fair, yeah, I think AI would definitely come in and help. I mean, but I think the sad thing is that AI still will not do the glucose test. AI would help us in actually, in maybe stratifying patients once it's got the markers in there. So, but someone's got to put the markers in there. somehow. So I think what it would help us do is AI would definitely be quicker and faster in getting in basically stratifying the patients for us. But the sensor, something has to sense what we're looking for. And that's still where I still believe that we still have to work on. So it's, AI is garbage in, garbage out. So effectively, you've got to feed your AI with the appropriate information, the right information, and then you will get the result. But I don't doubt it that AI will make life a lot more easier for us when it comes to diagnosis and management. But what I see is that our input of our data also has to be robust and actually be of quality. And that's the place I still feel that we still need some work on doing. That's just my gut feeling. But I'm looking forward to AI making my life much easier.
Yeah, thank you for that insight. Yeah, Dr. Agbor, do you have anything to add to that?
Yeah, I think John hit the nail on the head. I think the key for AI, as is he mentioned garbage in, garbage out, GIGO, as we used to call it in the back in the days. But I think the key is that you have to train the AI model, and to train the AI model, you need the right data, or as I alluded to. So if the training model is not right, or algorithm is only as good as the model you feed into the system. And I'm talking about generative AI. There are different forms of AI, and how you then, so that's from a diagnostic perspective, because you probably know that 4 years ago, the Swiss, or no, not Swiss, the Swedish guys came up with 5 endotypes of diabetes, type 2 diabetes. And that was based on multi-omics. I'm sure their life would have been made an awful lot easier, to use John's term, if they had AI at the time when they were publishing that paper in Nature. That is one thing. And so the training data is important, and that's why a lot of us on this forum advocate for representation of the populations we serve in the training data that goes to inform the AI before the AI can develop its algorithm to be able to, generative AI, I would say, because there are different forms of artificial intelligence and people can use them differently. The other thing to mention is that once you get a clinical data that's representative, AI can be able then to advise you based on the input of, say you have a patient in front of you, what would be the best laboratory testing, the height, the weight, and everything, the family history, what would be the best medication that could best give them better glycemic control. So that's to your second point, which is the therapeutic option. So there are different ways you can use AI, but I think the training model has to be representative of the population. I think it has to be used in the right way to get the best outcome for the populations that you serve.
Yeah, thank you for that. Okay, so I think we're just run out of time. But yeah, thank you to both our speakers, Dr. Agbor Akre and Dr. John Bolejoko, for sharing your valuable insights, and to our audience as well for your engagement tonight. So we've explored some critical topics such as leadership in underserved regions, pharmaceutical innovations, and the importance of tailoring solutions to local needs. So at Helps Global Association, we remain committed to driving impactful change in healthcare for less developed countries. So thank you so much for joining us. So make sure to follow our YouTube and have a wonderful evening.
Thanks for having us.
Thanks for having us. Thank you very much.
Bye.
Bye.
Bye.